Thanks to Dr. Eliza Eng at Emblem Health. So big round of applause for Eliza for everything you see here tonight. The beautiful space, the beautiful sunset, she did that too. So thank you, Eliza. It's very important because without the support of you guys and people like Dr. Eng and people like Meryl Greenblatt, who actually helped curate, so say a little no, who helped curate and got at least half of these speakers up here to come in. Guys like Jacqueline, who's working the camera tonight, Jeff Bornstein, the Chief Marketing Officer for MedStarter, where are you, Jeff? And of course, Pat and so without the help of all of our great organizers and team members, we would not be able to do this, and also for your support. And especially people like Colin and all of the people who, where are you, Colin? Raise your hand. Everybody who's a member of Health 2.0, who's a dues-paying member, put your hands up. I just want to say thank you to all of you. Thank you. Because you are part of the 1% of Health 2.0 New York, which supports and makes it so we can do these things on a regular basis. So we definitely appreciate that. Our next event is Leading Edge Technology in Healthcare. So if you've got leading edge tech, if you've got something really cool to bring out to market, we're hopefully here in the same place next month, Plaza. We'll be here on May 8th, or somewhere on May 8th. So without further ado, I think I've thanked everybody, okay, and you guys, and all the people who helped. And now, one of the key things about this is I don't know enough about this topic. So one of the important things that I always make sure I do is I find a really great expert on the topic. So that expert in this case is Brent Stackhouse from the New York City Department of Health and NYC Reach. So I'm actually going to let him run the show. And that's one of the great things about this. This is a community organization, okay? We're all volunteers here. All we really want to do is have a really great conversation about something I don't know enough about, right? So somebody proposed this idea. You guys all said, yeah, you thought it was a good idea. And then Meryl and I curated and we got the best we could find. So this is them, and I hope you enjoy the show. Everything that Dean said tonight is being recorded. It's available on medstarter.tv. Okay, so don't say anything you don't want to publish on the internet, which is usually a good policy anyway. I'm Alex Fair. I run MedStarter. As you can see, there's a whole bunch of MedStarter stuff in here, and welcome. Thank you. Come on.
Well, thank you, Alex. I certainly appreciate the opportunity to come and speak with you all tonight. I'm very excited about the panel, and I'm very excited about the opportunity to talk a little bit more about the Affordable Care Act. It is a highly contentious piece of legislation, and the opportunity to clarify some things and really have a thoughtful conversation with so many brilliant members of our panel, I think should provide some nice discussion and some nice thoughts for all of you to take home and think about not only how does it affect you in your organization, but also how it affects you as an individual. This thing with the Affordable Care Act is it affects us all. So to begin with, I want to give just a little bit of an overview of the Affordable Care Act. I love being called an expert because it doesn't put any pressure on you at all. It makes me wonder exactly how one goes about defining expert, but for tonight, I will play that role because I learned when I took a job in public health, working for a health department, you are ultimately the ombudsman for everything. If somebody's grandmother is sick, it is your fault. If healthcare reform doesn't work out, that's on your shoulders too. So I'm here to play that role. After we go through a little bit of an overview, I want to break into sort of two segments of the conversation. The first one is about the expansion aspect of coverage of the Affordable Care Act, and have the panel, as well as all of you as the audience, participate in that. We do have a microphone here. I'll be asking questions of the panel. As folks in the audience, if you feel that there are things you'd like to contribute or additional questions you have, please do line up to the microphone and I will field those from you. Then we're going to take a little bit of a networking break. We're going to come back. Dr. Mike Wolk from the Cornell Provider Organization will talk about how their organization is only the second part of the Affordable Care Act, which is about the expansion of quality and the reduction of cost. And then from there, we'll break into another panel discussion and have all the panelists discuss how they're surviving and thriving under these challenges. Unfortunately, one of our panelists couldn't make it tonight. He claims he was just broken by the yoke of the Affordable Care Act and couldn't come. But Dr. Sal Volpe is a good friend of the health department, and I know a real leader in the community around not only healthcare reform, but also health information technology. Unfortunately, had something come up and will not be able to join us. I will do my best to don the perspective of a small practice primary care provider, but much like being an expert when it comes to of the Affordable Care Act, I also have no background that's remotely clinical, so it should, at least for all of you, be entertaining. And if any of you happen to be a primary care provider that works in a small independent practice, please do feel free to go up to the microphone and share your thoughts and opinions about how exactly this is affecting you. So without further ado, a little background on exactly who I am and why I'm here. I work at the New York City Department of Health and Mental Hygiene. I work for the Primary Care Information Project, and what we do is we help providers adopt electronic health records and use health information technology to improve the quality of care that they deliver to New Yorkers here in New York City. We rolled out a program back in 2007 where we subsidized a specific electronic health record software program for exclusively primary care providers who worked either at federally qualified community health centers or in small private practices that saw a large proportion of Medicaid, underinsured, or uninsured New Yorkers. That program expanded, grew into specialists, that funding ran out, and then we were then federally funded through the Cae Act, which is a part of the our stimulus package, to help providers with their adoption, except we were no longer in the business of subsidizing the software for them. The onus was then on them. At this point in time, we now have 12,000 doctors in our program. About 2/3 of those are primary care, but 1/3 of those are specialists. This is exclusively ambulatory care providers. We do not work with inpatient doctors, folks who are hospitalists. And these are providers across the community, not only those who are treated the uninsured and underinsured, but also those who are treated exclusively commercial insurance, who have no insurance at all. And these providers work in a variety of settings, evenly distributed between small practice primary care, less than 10 doctors, community health centers, as well as hospital outpatient departments. We work with all but 2 of the hospitals here in the city now to help them with their transition from paper to electronic and then on quality of care programs. So our division, however, does 2 other things that are somewhat interesting. One is we run correctional health. All of the New Yorkers who wind up in jail actually get full health services. That is somewhat unique in the country, and our correctional health services are incredibly progressive here in New York. About 15,000 people go through correctional health every year. 40% of them have a behavioral health issue, and we have more than 30% recidivism rate. So these are folks who are in the community, and these are folks who are constantly coming back. So we actually do a lot around chronic care management through our correctional health services on Rutgers Island and some of the other facilities here in the city. The other thing we do is health policy and planning, and that is actually how I can purport to be somewhat an expert on the subject, because all of the good folks there actually do work on policy, and they are the ones who actually oversee organizations like the Patient Navigators here in New York City, which help people in their selection and navigation of the health insurance exchanges. So, that's who I am. Why are we here today? Because the Affordable Care Act is an unbelievably polarizing issue. It's very convoluted. It was 2,400 pages, not to mention the tens of thousands of pages of guidance that came along with it. Now, I put this cartoon up here for 2 reasons. One is, it is incredibly hard to find a funny cartoon about the Affordable Care Act that's in favor of the Affordable Care Act. I spent a lot on the public circuit. I had a lot of time on my hands. I spent a lot of good taxpayer money looking for this. And this was the best I could do. The second thing is it's not that funny. It's not really funny at all. And unfortunately, all of the funny ones are really against the Affordable Care Act. And I don't want you to think, as you come across this in my presentation, that I have some subtext in my message. I don't. It was just the best that I could do with a day's notice to find something remotely humorous. So my apologies for that. Now, can everyone hear me all right? I've got 3 microphones here. Okay. So, where to start? Affordable Care Act rolled out back in 2010. It was supposed to be fully implemented by 2014. It was delayed for a variety of reasons, which I will get into. Now, what's interesting about here in New York State is that we are incredibly progressive. A lot of the Affordable Care Act provisions were adopted very quickly here in New York. Some of the stuff had been underway prior to the passage of the federal legislation. So we're a little bit unique. So you'll see sort of throughout my presentation, I kind of call out things that happen here that you don't actually see elsewhere in the country. Why exactly it was needed? Over 51 million Americans are without insurance as of 2009, and that number was going up to 55 in 2012. And what we find is that uninsured patients are less likely to receive preventative care. And preventative care is ultimately where you are able to really make a big impact when it comes to the cost of care. You can actually get people away from adverse reactions that get them into expensive situations that are really exacerbated by not being treated up front. Simply, it costs more. And in terms of cost, in the United States, our healthcare system costs $2.8 trillion. It's not very often a public servant gets to use the number T in writing a number, but yes, $2.8 trillion. $800 million of that was going to Medicare and Medicaid. And Medicare and Medicaid was going up at a faster rate than both inflation as well as GDP. Now, does anyone here have an economics background? Good, so none of you know why that's important, which is good because I don't either. I took a semester of macro. I'm really not in a position to explain that, but it's bad news. That's all you need to know, that Medicare and Medicaid costs are going up at an atrocious rate, and it was really bad news. Also, a lot of people weren't loving the way the healthcare system was set up, and there hadn't really been much to make a move on it since the 60s. So the point of this new law is to expand coverage, put a focus on quality, and to reduce costs. Those are the simple tenets of it. Not being simple with 2,400 pages of legislation, there are about 12 main points, and so what I want to do is sort of gloss over these for each of you, so we all have enough information to be dangerous, and then we can turn into the panel and really talk about the expansion piece, which is just one segment of the Affordable Care Act. So this is most people's perspective of what it means to have 2,400 pages of legislation, that all we're doing is taking a smaller problem and making it a bigger problem. Though I hope some of the discussion from the panelists tonight will help to indicate that indeed there is really great progress underway, especially here in New York and New York City specifically, that's somewhat leading the nation in adopting some of the aspects of the Affordable Care Act that really seem to have some serious hope for making an impact in terms of cost and quality of care. So first section, the individual and employer mandates. This is getting everyone on health insurance. The deadline, as all of you know, was March 31st. Anyone here enroll for an exchange plan? Alex, you did. Yes, ma'am. Okay, so a couple folks here. And so show of hands, how easy was it? No, show of hands. And did anyone use the New York City resources, call 311, the health department? And that's why it was so hard for you. I kid. It was unbelievably convoluted, and each state did it somewhat differently. There's a penalty if you don't enroll in an insurance program by this year. That penalty is approximately $100 for an individual, about $250 for a family, and up to $10,000 for an individual, $20,000 for a family, depending upon what your income level is. And those penalties, you're in luck. They go up every year if you're not insured. Now, there are some exemptions if you're incarcerated. If you were one of the people on Rikers Island getting those wonderful correctional health services from the health department, you are not able to be covered. Otherwise, if you are not lawfully present, which honestly, I'm not a lawyer, I'm totally clear what that means, or if there's small gaps in coverage along the way. For employers, for small businesses, if you have more than 50 employees, the onus is on you. Now, another question for you. Anyone here enrolled in a health insurance exchange plan because their employer said, we're going to cut our existing insurance program, and you're going to go into that, I'm just going to reimburse you? No one? All right, that is indeed happening out there, and it is perfectly legal. The benefit for the small business is that it reduces the amount of administrative burden in actually managing the insurance programs on behalf of their small company, and instead just push that expense back on employees in many cases to reimburse them. What's interesting about that is that it actually becomes somewhat of a taxable event, and again, much like not being an expert in the Affordable Care Act or a lawyer, I'm also not an accountant, so I cannot get into the details of that, but if you do find yourself in a situation, I highly recommend you speak to your local CPA. In terms of the second section of the Affordable Care Act, it was insurance reforms. So health plans have to take everyone. This is the guarantee issue. Now, New York had already put this in place. Again, we're progressive. You like coming out up front. There are limits on the premium cost by age, area, family composition, history, tobacco use, for example. Now, this varies. There, again, are limits. Those limits are somewhat negotiable, sort of state by state. Here in New York, they adopted all of them. What is referred to as a pure community rating. That means it's not allowed to vary your premium. What it costs you to get insurance cannot vary by any of those items there in the state of New York. A couple other states adopted that as well. By and large, that has not been the case. It's a little bit more sliding scale. The good news is that it has been capped. Coverage has been extended up to the age of 26 for children here in New York, 29. So does anyone here have a under 29-year-old child at home? Well, they're never going to leave now. They don't need to. They'll have health insurance until they're in their 30s. So here in New York, they are covered up until 29. Cannot exclude someone as a result of a precondition, And plans have to spend a certain amount, 80 to 85% of the premium money on care. So they cannot be pocketing massive profits. That is known as the medical loss ratio. The other thing is there are no lifetime or annual limits on premiums. I'm sorry, on coverage rather. And there are, however, some grandfathered plans. Just to gloss over that quickly, any plan that existed before March of 2010 could potentially have been grandfathered in. They don't have to cover preventative care for free. They don't have to guarantee a right to appeal. You can read the slide as well as I can. The good news is we're actually seeing a reduction in the number of grandfathered plans that exist. We hope that this is a trend that will certainly continue. But if somebody here, and I don't care if anyone here in the audience, have you been on these same plans since 2010? Right, so it doesn't affect anyone here, but in other states this is actually a little bit more of a problem. Now, next section, Medicare, benefits and reforms. Like I said, $800 billion goes to Medicare and Medicaid. Lots of focus on trying to reduce costs there. On the Medicare side, trying to incentivize physicians to do more around primary care and preventative care. They put together a 10% bonus payment for primary care services that goes through 2015. Anyone here a primary care provider? On the panel? Ben, there you go. Ben, did you get your Medicare reimbursement?
It was my employer, yes.
Fantastic. Good. Very excited for my son. Advantage plans, for anyone that is in an advantage plan, medical loss ratio has to be at least 85%. Emblem, you all have an advantage plan?
I have everything.
Like that. And then we have to increase the transparency of Medicare costs. Now, this is an interesting one, and it's actually incredibly timely. Today, they released data on 880,000 physicians. This is their Medicare claims data. It is out there in the world for you to look at. Our organization, the health department, has already downloaded it and are scouring through it now. What's great about this is it starts to give a better sense of what do services cost, what are providers charging, how does it vary from location to location. And some of this data has been released previously. I'm not sure if anyone read the article in Time Magazine about a year ago, almost a year ago exactly, that Stephen Brill wrote called Bitter Pill, but it talked about Medicare costs that as seen in hospital settings and the disparity in costs between hospitals across the street from each other. In some cases, the rather surprising costs that hospitals are willing to pass on for things that a consumer walking into local Rite Aid or Walmart would be able to get for a significantly less amount of money. And they got a lot of people talking. Now, I certainly cannot say whether or not Stephen Brill's article is factually correct. I know there's been a lot of controversy around that. But I do know that the interesting thing about this data is it brings a lot of people to the table talking about something that historically was never possible. And as policymakers, and as people really trying to make a big difference in terms of how people are able to access quality of care at a reasonable price, the health department here in New York City is incredibly excited about this. We're starting to look at this data to see what exactly is happening to the providers here in our community and what can we do to make a difference. The last piece of the Medicare benefits reforms that I want to highlight was the donut hole. Now, for those of you who are uninitiated, what the donut hole is for Medicare Part D, which covers prescriptions. And the way it worked was if you spent, I want to make sure I get the numbers right here, if you spent up to $4,500 that you did not have to, I'm sorry, $2,800, you did not have to come out of pocket on. That was covered. But then, between $2,800 and $4,500, you did have to come out of pocket on, but then after $4,500, you did have to come out of pocket on again. And what we saw was a lot of elderly people who were on Medicare just stopped taking their prescriptions at that point in time. And that's bad. That's certainly an inadvertent result of that policy. So, one of the big parts of the Affordable Care Act regarding Medicare reform is to fill the donut hole. And this is one of the few times somebody from the Health Department of New York City will talk about filling donut holes in a positive way, I assure you. Now, this is the bread and butter. This is why I specifically am here today, and why many of our panelists are here today, and this is going to be the real focus of the second part of our panel discussion. This is the focus on prevention and public health. This is where the real meat of the Affordable Care Act comes to play there, beyond the insurance piece that really affects each of you as patients. The first one is preventative services. Trying to reduce cost sharing or remove cost sharing, that is your copay. You should not have to pay $15, $20, $50 to go see your doctor to get screened and to get preventative services. But that should be free to incentivize you to want to go do that. It increases Medicaid payments for primary care doctors. The primary care rate increase, Ben, I doubt you see much Medicaid, but being the only person here in the audience that's eligible for it. Did you enroll for your PCRI increase?
I plead the
I believe the fifth, that's all right. So interestingly, here in New York, they laid out a program for New York State Medicaid that said if you're a primary care doctor and you billed Medicaid in 2013, anytime between January and December, if you submit one piece of paper with your number on it and your address, and you fax it in, they will reimburse you all of those payments at a higher rate. So if you're a primary care doctor, you chose not to raise your hand earlier, this is a really big deal. We can certainly help you submit the paperwork. A lot of doctors didn't realize this happened and sadly missed the boat on it, which again, a little counterintuitive if you're trying to get doctors to want to do more preventative care. But looking forward into 2014, 2015, there's a lot more attention around this. And keep in mind, Medicaid generally does not pay particularly competitive rates. And so a lot of primary care doctors have been historically disincentivized from wanting to see Medicaid patients. So we were certainly excited that not only the Affordable Care Act include this, but that New York State Medicaid made such a big push to get this rolled out. The other big thing was increasing the federal contribution for states that cover preventative services and immunization, so less onus was on state budgets, was coming out of feds instead. And that, again, the Medicare bonus existed. Second piece, building capacity workforce, is getting more people into the healthcare sector because, as you all have noted from head nodding earlier, this is really complicated, and it's going to take a lot more people to be involved in order for us to navigate this for patients. Because it's not only about navigating your care as an individual, where more onus is on you to take care of yourself, but also navigating the healthcare system, which has become even more convoluted. And so providing the ability to have greater capacity in the healthcare sector for those workers. Also, put money into community health centers and school-based health centers, and you'll be seeing a lot of legislation coming out of Albany around expanding community health centers here in New York City specifically, and Brooklyn in particular in the coming months and years. Policies in education, again, understanding that patients need to be better consumers of their care. How do we do that? We have to educate the patient, provide programs where that is indeed possible. Also, how to influence the environment around the patient, things like nutrition labeling and public health campaigns around nutrition, physical activity, smoking cessation, of course. And then something that I was really excited about, community health assessment needs, because this is, again, core bread and butter for a city health department. Where are our problems? How can we identify where the hotspots are? And what can we do about it? And this provided funding for that. Lastly, in terms of public health, again, incentives for chronic disease management in Medicaid, more money for community transformation grants, which my bureau was indeed a recipient of, which we focused on tobacco cessation program with, and then lastly, prevention and public health fund. Anyone here heard of the Prevention and Public Health Fund? All right. Maybe some of you know it as the Obamacare Slush Fund. This is Kathleen Sebelius. I had a chance to meet with her in January. She's lovely. And just 2 points here. One is when she's shoveling money out the door, she wears gloves. And two, the pile on her table is like half the size, I swear. Kathleen Sebelius has been a huge proponent of health information technology, and the Office of National Coordinator has been one of our main funders. And she has taken a tremendous amount of heat for a lot of things that we and our bureau have seen as being outside of our hands. So what exactly was the Prevention and Public Health Fund? Well, theoretically, it was $2 billion a year to go for workforce and infrastructure, community-based prevention, clinical prevention, and research and tracking. But it became something of a political pinata. A lot of money got gutted out of it. 2011, only $750 million was funded. 2012 was the last year that it was actually fully funded. In 2013, $949 million was funded, but they took half of it away and they put it to the health insurance exchanges, which this was not supposed to pay for originally. Now going forward in 2014 and beyond, that money is all getting funneled through the CDC, the Centers for Disease Control, which is run by our former Health Department Commissioner, Dr. Tom Frieden, who again has been a big champion of the Primary Care Information Project. Gave us a nice little award last year. But that money's going to go to him first before it goes into these targets. And what I would do if I was Dr. Frieden, I used to work for him, he's a savvy guy, he'll fill his budget caps first, which the CDC has many, and then the money will trickle through for his programming. So it's a shame that Prevention and Public Health Fund has been gutted in the way that it has, because ultimately what we're talking about here is trying to deal with good smoking. We're talking about trying to provide data through the Patient-Centered Outcomes Research Institute that helps inform how patients can get better access to care at a better rate without compromising the quality of care. And that's a big, neat chunk of this program that sadly is at the point now where it's been so highly politicized, it's been negatively impacted. So I'm certainly curious to hear from some of our panelists later how exactly they see the impact of the PBHF program being witnessed through the work that they do. Lastly, quality and care coordination, quality measures for Medicare and Medicaid, trying to standardize those. More care for dual eligible populations who fall into both categories. New payment models around hospital-acquired infections and hospital readmission penalties. The rates, I think I have a handy little statistic here around this. The rates around hospital readmissions back in 2012 was really astronomical and somewhat unconscionable, because what would happen is a patient went into the hospital and actually incurred, had some sort of adverse effect as a result of their hospitalization, or worse, had an infection. The hospital then get paid to cure the infection that they ostensibly caused. Let me see here. So 1 in 5 in 2009 who were admitted were readmitted within 30 days. And it cost an estimated $4.4 billion in 2009 as a result of this care. And then $26 billion went to hospital readmissions in 2009 as well. I mean, the numbers are astronomical. So what the quality and care coordination component of the Affordable Care Act is focused on is how you now disincentivize hospitals and how you get sort of a more rational payment model in place so you're not paying hospitals to effectively clean up issues that they potentially cause. And it'd certainly be great to hear from our hospital panelists on how this is impacting them as we go forward. Two other things that I think are pretty compelling, and we have some representatives on the panel that cover this as well, is the accountable care organizations and health homes. So first starting with accountable care organizations, who here has heard of an ACO? Wow, fantastic. So for those who have not heard of accountable care organization, the concept is this. It's also known as a shared savings program. The ACO program is the Medicare specific one. You take a group of doctors, you identify a set number of patients, you make a baseline of how much their care cost last year. Say 10,000 patients cost $10 million last year. And if they are able to save any money, they get to keep half of it. So now all of a sudden the onus is on these providers to really track the patient throughout the care continuum and try to reduce costs while ensuring there's good quality of care, because ultimately if your patient winds up in the hospital, that's amazingly expensive and will impact your ability to make reductions on that previous threshold, that baseline that you may have had. Now health homes is a little bit more convoluted, but ultimately what you're trying to do is create care coordinators for those who are afflicted with chronic disease and severe behavioral health issues. Here in New York City, we have 11 health homes. They're tracking these patients across their care continuum and trying to ensure that they are navigating the healthcare system in an effective and affordable way. The health insurance marketplace, so just to dive into this very quickly, there is one marketplace. There are two programs, one for individuals, one for businesses. Humorously called the SHOP program. I guess the SWOP program was not quite as marketable. Who's not eligible? Anyone on Medicare, anyone who's undocumented, and where the enrollment periods, anyone in Medicaid or child health insurance program can enroll all year, children's health insurance program matter. However, for everyone else, the deadline is the 31st, as many of you know. The next enrollment period, November 15th. So if you missed the window, you have one more shot at it. If you have any questions, New York State of Health guideline.gov is available to answer them. What do these health plans have in common? Prevention, outpatient services, mental health services, maternity and newborn care, hospitalization and emergency services, occupational therapy, labs and imaging, pediatric dental and vision, and prescription drugs. In New York, these are all covered. In other states, some of these not completely. There are a variety of levels of plans. The cost of the plan that you see here this is the bust out retail cost. Many folks qualify for subsidies and will never pay this, will never actually see these numbers. But if you were to come off the street and make more than 400% of the federal poverty level, these are potentially the rates that you would pay depending on which plan here in New York that you go with. There are various levels of care. So counterintuitively, those who pay more are ultimately getting a higher contribution from the health plan in the payment of their premium. Going down to catastrophic coverage, because apparently the U.S. men's hockey team is not available for a photo when it comes to the Olympic scoring system. But the catastrophic coverage is for anyone under the age of 30, and it's significantly less, but again, it really only covers catastrophic coverage. This is certainly not my area of expertise, but I do know there are some panels who this does help. Here in New York, there are 10 plans with a variety of products. Most products are available in all the boroughs. There are also, of course, dental plans as well. Public health coverage for Medicaid is anything under 138% of the federal poverty level. Just as a reminder, federal poverty level for an individual is $11,500 approximately. For a family, it is about $29,000. And again, these rates that you see here are just in New York State. Now, for those who are eligible for financial assistance, it's anyone between 139% to 400% of the federal poverty level. What does that come out to? An individual about $45,000, a family making about $94,000. I'm actually just going to gloss over the Medicaid piece. Just two things to note. One is this is going to cause about 40,000 Medicaid patients to be eligible here in New York City that previously were not, which is very exciting. And that the Changes in Family Health Plus program as well will put more folks into the Medicaid program and also transition some folks to the Marketplace program, where previously they were on the Family Health Plus program, which is being phased out by the state. Now, for those who are qualified for the 139% to 400%, again, pretty straightforward. There's a premium subsidy for some as well when it comes to your co-pays. But the thing that's interesting here is that this is just New York. And across the country, this isn't the case. What the eligibility levels are vary state by state. In Texas, a family of 3 has to make $4,800 to qualify for Medicaid. $4,800 for a family of 3. If you're an individual, no coverage for Medicaid. If you make more than $4,800, you don't qualify for Medicaid. Not until you're at 139% of the federal poverty level does a subsidy program kick in. So it's a little counterintuitive. You're leaving a lot of people behind here when it comes to health insurance. And ultimately, the federal government right now is putting money out there to support these state Medicaid programs, and the states are just choosing not to take advantage of it. So we're very fortunate here in New York that there are no gaps in care. That's not the case nationally. So if we put another part of this program is customer assistance for the Marketplace. A lot of opportunities there. Here in New York, the certified application counselors are actually provided in part through our division. And what has the impact been? About 500,000 patients we expect New York City to gain insurance coverage by 2016. What have we seen so far for enrollment? They're hoping for 218,000 to enroll. Almost 1 million people enrolled as of April 1st, which is tremendously exciting, but also really scary. Because we're talking about bringing a lot of people into the healthcare system who previously weren't there, and a lot of our healthcare system right now is at capacity. So, I'd like to turn now and bring the conversation to the panel. How are we surviving and thriving with all of these changes? Today, the first panel I'd like to focus on health insurance expansion. These 908,000 newly enrolled patients, what is the impact of them going to be for you? So, I'd like to start, turn to Dr. Eliza Ing from Emblem Health. Again, thank you so much for hosting us today. Eliza, you're in a very interesting position. As you said, Emblem Health has a variety of plans. How do you see this impacting you? Why is Emblem Healthcare in the health insurance marketplace business?
So, in general, so let me talk about, in general, health insurance companies. There's myriad reasons why companies get into business. Geography. Some national plans really decided that because of their national coverage, it's very difficult for them to really be able to adhere to each individual state's sort of specifications, for instance. I think more importantly is business models. So plans that are actively engaged in exchange, maybe not so much in New York, but others like Norfolk has always been in individual markets. So they feel relatively a comfort level and expertise, I believe, in managing sort of the individual risk. Versus you have plans such as Cigna, whose business model is really group health insurance, working with employers, and perhaps their appetite for risk in this context is less. So for us, it completely makes sense for us to get into the exchange for myriad reasons. As Brett said, we are the only health plans in New York.
Is that okay? So we're the only plans in New York that offers a whole complement of products, from commercial large plans to Medicaid, Medicare. And so by offering product in exchange, essentially, we're able to service the individual across the continuum of employment status, right? So whether you're employed by a large company, you get employer benefit, to individuals, to Medicare, we can service you, and that creates a continuum of care. We've had a very long history of managing risk, full risk of a membership, and so clearly we're not afraid to get into the individual market without really have a good sense of the risk pool of this market. We have a very high-performing network. We actually have an integrated delivery system. We own a 450 physicians practice that across 40 offices across the world. And we believe that leveraging these high-performance networks, high-quality, very efficient network that delivers relatively cost-efficient care is going to be our strategy to maintain the financial viability of the product. Again, don't forget, all of us have no idea what the risk pool is. And so we're in it for the long haul, but we believe that we can manage the risk of this population. Lastly is engagement. Because of who we are, we're a local plan. We also believe strongly that we have the ability to deploy efforts at a local level, community level, neighborhood level, that could really improve the engagement of the membership. So we'll talk a little bit more about engagement and why that's important, but that's the reason why we get into this.
Thank you, Liza, and my apologies, I have a slip of my mind here. I might actually first go through and make sure everyone can introduce themselves on the panel here. So Ben.
Sure. So my name is Ben Forrester. I wear several hats. One of them is that I am medical director for the Mount Sinai Health Network. And in that role, I'm in charge of all our clinical strategies at Mount Sinai in terms of our relationships with physicians, with large practices, with hospitals, international relationships. And then I also am the chief operating officer for the Affordable Care organization called Balance ACO that primarily is in Upper Manhattan, so Washington Heights, Inwood, and the Bronx.
My name is John Marr. I'm a founder of a company called Inspectos. I describe Inspectos as an innovation consultancy. We really focus in on helping health organizations, whether they be payers, pharmaceutical companies, public health organizations, really understand how to engage with consumers as well as health professionals to change health behaviors. And so a major focus of ours actually is on health technology, specifically mobile technologies, wearable devices, and the whole gamut of tools that are being used by consumers and physicians. Another reason that I'm on this panel is that I recently co-authored a book called E-Patient 2015, which actually focuses on 15, which Brett has there, 15 trends that are changing healthcare, not only in the United States, but around the world. So one of the things that we actually did in the book was look at the Affordable Care Act and focused on how technologies are being used to reduce costs, as well as change patient and provider behavior with using a range of health technologies. So we're happy to be here, and thank you, Alice, for the invitation.
I'm Michelle Zimmerman. I'm Chief Innovation Officer at Affordable New York. Some of you, actually, show of hands, has anyone heard of Affordable New York? Oh, a few, 2, 3, only because I know these people. But no, Affordable New York is actually a startup health insurance company. We're based in Brooklyn Heights, and we're really taking advantage of some of the things that we heard earlier today around the expansion of enrollment under the Affordable Care Act. Specifically, we have a number of products. We're in the managed long-term care space. We have a Medicare Part D product. We have a couple of duals products for individuals with disabilities, institutionalized individuals, and we're in the running for New York's FIDA program, which is a demonstration project around how to manage the sickest of the sick population, people who are receiving money from both the federal government under Medicare as well as from the state and Medicaid. And I think it's great that we're sitting next to each other because you guys are probably wondering, what does an innovation person do in a health plan? But basically, what my responsibility is to think help manage this very unique population across the continuum of care. We do a pretty good job at helping people who are healthy, and we do a fairly good job when somebody's in the hospital, but all of that space in between is really a black box. And when we think about, I think, what, $800 billion that's being spent on Medicare and Medicaid, there's a great opportunity to do this better. And we can look about engaging the patient, engaging their family. We want to be partnering with providers, and we want to be using technology. And we need to figure out a way how to bring this all together.
So I'm Michael Walker, I'm a cardiologist in the 10-person cardiology practice at Royal Cornell. Past 13 years, I've been manager contracting for full-time faculty at Royal Cornell, and just going to be stopped. So
So, Liza, you mentioned the issue about not knowing what your risk pool looks like, because we just don't know who's active and enrolling right now in these programs. And I'm curious, far from your research, what do we know about some of these patients who are on the exchange?
Yeah, actually, it's actually very interesting, not the research that we've done, but the New York Times recently released some research actually looking at who's enrolling in these exchanges. And one of the things that they found is that the patients that are consumers that are more sick are the ones that initially who have been enrolling in the plan. That actually makes a lot of sense because those are folks who haven't really had access to either complete insurance or have not had care at all. And so, this has been seen in other areas where things like, Medicaid and Medicare have been, specifically Medicaid, have been expanded. We see more sicker population actually coming into the pool. Now, this is concerning, companies like Emlyn and some other companies because potentially, because, the sicker the population, the more costs that are associated with them. So, that's something that people are looking at very carefully with regard to, what people are looking at. So, I'll let you jump in there as well.
Yeah, so that's a good question. No one knows, right? So, but unlike you who actually do research and really try to be an expert, I just bring a friend. So I want to introduce to all of you Sana Hashmi. She's our Director of Healthcare Reform. And she's really been in the trenches. She's, her and her team have developed our product, rolled it out, and now are really dealing with some of the administrative things or issues around the exchange. So Sana, can you give the audience a sense of who do we have at Emblem or in the exchange world? Demographics, age?
Yeah, so definitely older than anticipated. Average age sitting around mid-40s. Whereas anticipated that you have about early 30s, mid-30s rollout, uninsured being historically the young invincible, the younger generation entering that can afford it. Not the case. We did see a push towards the end of March as the open enrollment came to a close. A lot of the young people who were just sitting around finally got around to filling out those applications and coming in. We saw a shift. The fee did drop slightly, but not where we thought it was going to be. So that's different. And we have to sort of now work with our clinical team to reevaluate some of the models that we established beforehand, anticipating a very different sort of outlook and demographic structure. We saw a lot of individuals who entered early, being your traditional those that had insurance, a lot more than we thought, not as many uninsured. So we're not yet sure what that uninsured population really was out of that 1 million so that came in. We know there's some in there, but is it traditionally all of them uninsured? Most likely not. From our data, we're finding that we did end up getting back a lot of the people that are already part of the direct pay market and were already purchasing insurance. They got a much better rate on that insurance, but they're not really that uninsured that we're tapping into just yet. The open enrollment period, though, is over. There's still a lot still left to be done, right? There's special enrollments, qualifying events. People can come in and out depending if they lost coverage, if they got a job, lost a job, had a kid, got married, got divorced. All of those things can qualify and get people insurance. So we'll see how this evolves as time goes. There was a big push on pent-up demand. People thought they were going to be out the door, number one, everyone's going to be knocking on the door of hospital planning care. Not the case. We haven't seen it just yet. We are seeing drugs, prescription drugs, people trying to get drugs that they haven't, gotten before. But are we seeing it on the inpatient hospital provider side? No, not yet. So we'll see as time goes what this population really looks like. It's not completely what we anticipated it to be. I can tell you that.
So let's talk about the plans for a quick second. I'm curious, how is exchange plans different
than the plans that would be offered by a company, particularly the group plans, especially large group plans.
Simon, do you want to start? And I want to get back to a very important notion about narrow network, because I know there's a lot of discussion around that, so I want to come back to it. But Simon, why don't you talk about sort of the plan design of the exchange plans and how it's compared with your traditional indemnity plan or other large plans, for instance?
Yeah, so you see some new benefits, right? Physical therapy, occupational therapy, speech therapy, all covered. Generally, could be covered out, not covered. Prescriptions baked in. Generally, in the group market, prescription is purchased separately as a rider. Some groups offer it, some groups don't. New York has a much higher uptake of prescription and groups offering it. Other states, not so much. But that's now embedded inside the product. You get things like pediatric vision and pediatric dental, which you don't generally see inside commercial plans, are inside this as a medical benefit that aren't in group plans traditionally. The other thing to be aware of a little bit about these plan designs, if anyone has it, they're designed a little bit differently. They have what's called an upfront deductible. An upfront deductible is something that you have to pay out of pocket before the health plan starts paying. So you can see these on these plans. New York's not used to that at all. We don't usually see that in the New York market. They're usually copay-based products. So you go to the doctor, you pay $20, right? In the case of these plans, you might have to pay $200 or $400 first before you start paying those copays. I think it's going to be interesting because when people buy insurance, one of the things they think is, well, I have insurance, so I'm covered, right? And when they first see that provider bill at the door and it's $130 or $115 and they're paying that first dollar before the insurance company pays it, I think that will be a surprise. So we'll see how that also plays out.
So in terms of the scope of who is eligible in the network of the exchange plans, how are they different? And before our sponsors answer, I'm curious, Dr. Wolf, Dr. Cornicer, do either do accept patients that are on any of these exchange plans, any of the 10 here in New York City?
I think we just had a very good statement that health insurance is not health care, and that's really a major concern, I think, all of us on the panel and everybody in the audience, because I think these plans are, a lot of physicians are not part of the plans, a lot of physicians were not chosen to be in the plans, there's no out-of-network benefits, I don't think you mentioned that, and there's these deductibles, so I think my concern, to be very honest, is access, listening and accessibility.
I think it also brings up the issue, there's going to be a very multi-tiered approach to healthcare where plans that are offered are going to give patients the opportunity to get healthcare, but maybe not at certain institutions. For example, while Fennell or Mount-Sinai are unlikely right now with the current programs to be offered. The other challenge that hospitals are seeing is that as you have these high deductible plans where people have an expectation to pay up front, hospitals are used to taking care of patients and having bad debt, but they're not used to that. What they're not used to dealing with is that this bad debt is now coming from patients who purportedly have insurance products. So I think that's going to be a issue that hospitals are going to have to think through.
All right, so first of all, how many people have heard of the notion narrow network, right? It's something that's kind of, right? So I'm going to throw out some numbers. So first of all, how many people think it's not a great concept? Like in the scale of positive to negative, it's more of a negative concept, a negative impact on your life. Okay, well, I think the rest of you are just fine. How many people have heard of Kaiser? How many people think that Kaiser actually delivers pretty good quality of care to their members? Kaiser has a narrow network. Okay. How narrow is narrow? I mean, only one person actually went through economics studies in college. Yeah, but I've learned something of relativity, right? It's all relative. Do you think 15,000 physicians is a narrow network? So first of all, that's sort of my...
And just real quick, there are 30,000 physicians in New York City, yes.
That's right. So it's framing. Now, think about it. How do plans, or we create a product that is pretty low cost? Sana can tell you exactly how much premium we collect from these products. How do we create a financial viability of a product? Triple aim, right? Improve care, improve quality, improve experience, lower cost. How do we do that as a plan? By only working with strategic partners who are committed to improvement in care management, improvement in care coordination, improvement in the referral pattern. And I'll be honest, it's an important component, is that we can create a product that is financially viable. If a product, like the exchange product, ultimately becomes non-financially viable with these 10 plans, who is going to lose? So, I mean, and we see it in our data. We see it from our data around the strategic partners we provided with. They have lower costs and they do also have higher quality. In general, it's a very general statement, but that's sort of how we chose our partners in these networks so that we can work closely with them. I only have 300 care managers. I can't deploy 300 care managers and I only have 6 physicians. We can't service, right, 20, 50,000 physicians. If we have to collaborate with them, I have to also scale that interaction because I can't collaborate with the whole network.
Thank you. So I'd like to first take a question to the audience and then back to Michelle.
Yeah, I know a lot of people bring up Kaiser, Mayo Clinic, et cetera, but those are exceptions to the rule. They're also not cheap. You know, Mayo Clinic, you know, you want to go to Mayo Clinic with Medicare, you want to go to Columbia Cornell with Medicare, or I'm sorry, with Medicaid. So those are expensive, actually, you know, fairly expensive models. In addition, you know, in a place like New York, the chosen partners are not necessarily based on quality, and you know that.
So I think that's a great point, and actually fits right into the comment I wanted to make. So I've seen this concept of narrow networks from maybe 3 perspectives. In my current role at Obamacare and in my prior life at Aetna. So maybe I'll speak in each turn and I'll call out, I use the term efficient networks and define efficiency both from a cost and quality perspective, and maybe that will hit on the point that you were making around Kaiser. So in AlphaCare, it was really interesting is when you think about, you know, the Medicare world, we have regulations, we have star ratings. So you have the government pushing down different quality ratings that have to do with procedures, making sure physicians are doing certain screenings and tests, outcomes-based measures, and as well as patient satisfaction. And I think that's actually great because it provides a window into who are the providers you want to partner with. From a cost perspective, we at AlphaCare actually take risks. So we'll get a set amount of money from the government, could be $10,000 a month to manage one of our sickest members. And we can say, well, what are we going to do with this money? So we're going to go out, like Eliza said, we're going to go out to our provider partners, and we're going to partner with them. And we're going to do some sort of agreement that will pay them more money. Pay them more money if they're going to speak with our members, participate in interdisciplinary teams, and we're going to hold them accountable. And that's when we're going to understand that quality, and that's when we're going to understand that cost, and that's going to help us build that efficient network. And we need to do that because that's when we stay viable, when we're taking the risk. When we turn to the Aetna world and the commercial world, so, you know, Aetna's bread and butter used to be a national accounts business selling to big companies, and so they're making group employer products. And you actually really want to have broad networks to provide for accessibility, but what the health plans are starting to do now is those networks, again, based on cost and quality. So they'll look at all their providers and they'll say, you know, did somebody do the right screening? How much were we paying? Were they doing unnecessary tests? And that helps us really understand and start right-sizing just certain practices. And then with our ACO partners, so Aetna has a huge ACO business. For them, understanding who their network is and partnering with those people is also critical. So I think narrow networks are here to stay, and I actually think it's a good thing, provided accessibility is there as well.
So I think the plan strategy is certainly fascinating, but I want to pull the conversation back over sort of the patient experience as a result of the expansion of care. And I'm curious, Mark, what do you see sort of price transparency across insurance products being, in terms of how do you see it impacting what patient experience is going to be like?
Well, actually, I want to kind of take a step back away from kind of price transparency for a second and kind of intricacies and more to the full kind of the fuller patient experience, right? And I want to even go beyond the ACA for a second and talk about, you know, all of us, I think, have a lot of experience in health. We've seen these kind of explosions. We saw, you know, HMOs. We saw, you know, we saw a range of things happening across healthcare over the years that have placed more and more pressure on patients and their families, right? And so When people were talking about the Clinton plan, right, years ago, a lot of behavioral economics people were talking about the rational man, making decisions based on, cost. And if you look at the Affordable Care Act from a behavioral perspective, it's really a behavior change piece of legislation where they're trying to change behaviors among providers, payers, as well as patients. And so one of the reasons I think that the Affordable Care Act, from a consumer perspective, beyond the plans, has had such a hard time with consumers, is that we never really, and when I say we, I mean the health industry, has placed people under certain assumptions for a long time, right? I go to the doctor, I pay my $20 copay, I can see the doctor I need to get the medications, etc., right? Now we're entering into an area where you're talking about narrow networks, first pay, wait a minute, I have to pay $400, because I just had a baby, or, $10,000, or whatever it is. So there's a tremendous behavior change experiment happening right now in this country, in the United States and across the country with regards to reform. And one of the things that we found in our research was specifically around the time that the exchanges first opened, which was a really tremendous opportunity to explain to people, both on the government side, the payer side, media side, exactly what was going on. And what we found is that there was a tremendously low amount of education happening. People were talking about the, healthcare.gov falling apart. I mean, they really should have been talking about the fact that if you get into an exchange plan, you might have to pay $400 up front. Or, if you work for a small business, your small business may decide, I don't want to be in the insurance game anymore, right? And so in this effort to reduce costs, increase quality, all these things we're talking about, the consumer or the patient and the caregiver has had absolutely no education about how to manage this system. It's almost like, when the 401ks first came out, remember that? And everybody had to get educated on what's a 401k, and what do I, we had all these resources put into play to help people on the corporate side understand the 401k as we move to kind of privatize the system and place more responsibility on patients. And so, right now we're in a giant, behavior change experiment, and we don't know what's going to happen. And so on the provider side, payer side, patient side, it's not just price transparency. It's being educated on the plans. It's almost like, with Medicare Part D, happened, right? All these seniors are like, wait a minute, I've got, I don't have to pay a prescription, but I have dental. What do I do? I mean, it's just a huge, I think, to be frank, they use really harsh language. There was a fiduciary duty for people to really educate, and we failed at that, just completely failed. And so I think that's a central problem that we have right now with quote-unquote insurance reform in this country, the fact that it's a giant behavior change game, and nobody's telling that to consumers. And that's what we do.
I agree. I call it the healthcare IQ, right, for lack of better terms. You have financial advisors, or you turn to experts who can help you manage the finance component. I think very similarly, an innovation needs to occur where you really have that component to improve people's healthcare IQ. Because healthcare, and even the end game of ACA is, we're still going to have a pretty fragmented system, right? Until we have a single payer system or single delivery. So until then, there's a lot of knowledge to be had around just sort of navigation and roles and responsibilities, both from a financial perspective, but also I think from a self-management, behavior change perspective.
I think the good news is there's a lot of, folks not traditionally from healthcare who see all these problems and are building companies around that. So there's a company called Wealthy, which is New York based, and they're actually helping individuals understand whether they're eligible for Medicaid and Medicare, and doing the entire process for them to get that reimbursement. There's, smart exchanges like Liaison that was acquired in Maxwell Health that are doing a curated shopping experience for individuals to figure out what plan they should even be on. So I think the good news is there's a lot of innovation out there that are filling the gaps. The question is, can we marry the old and the new?
Now, a lot of these are tech solutions, correct? A lot of these are web-based applications.
I would say a lot of these are definitely grounded in technology, but depending on the population, will have to be augmented by human touch, especially if you think about, an older population, a poorer population who might not have access. So technology is a capability that can be used as an enabler, but it needs to be sort of the hospital, the big kahunas in the room to drive that effort in a partnership model with those new technologies.
So with all these new entrants into the marketplace, I'm curious from the perspective of providers here and representing Sinai as well as the Accountable Care Organization, how are you guys positioning yourselves to deal with what we foresee to be a lot of new entrants in the marketplace, a lot of people who are coming to the market, coming into your offices who haven't had preventative care in a long time, if ever. So, start with
So, you know, the walk that out, I think, sort of segues very nicely what we were talking about before. So, one of the clear changes through the Affordable Care Act was that the amount of data that patients are seeing in terms of cost information is overwhelming. They lack sort of sophistication to really interpret that data intelligently. Unfortunately, the same exists for providers. So the amount of information that providers are now expected to navigate on a daily basis in terms of what procedures cost, what the meaning of different networks could potentially mean is tremendous, and the solo practitioner certainly lacks the knowledge on a day-to-day basis to understand and interpret all those relationships. So it's happening certainly in terms of large providers. I can speak, from outside and balance, developing integrated health networks, developing collaborations, trying to figure out how care should be delivered, not only in places where there's a high population density like Manhattan, but how do you deliver as you go further afield? How do you deliver it in areas that may be underserved, like the Bronx? So in those cases, there's significant recruitment of primary care providers right now, and trying to sort of bring them into the system and do things as efficient as possible. This is a tremendous challenge.
Well, I think as your slide showed, there's maybe 150 products with 10 plans. Each plan is different, each product is different. The educational expenditure, just to educate the front desk person, much less the doctor, the presentation, the costs are enormous going forward. And there's a lot of costs that are just under the table. The cost of the pre-certification for psychotropic drugs, the cost of pre-certification for oncology drugs. 80% of these drugs need to be pre-certed. And here you're talking about a payment system that's low, high co-pays, deductibles, a lot of problems collecting dollars, and a lot of work on the physician's part. It's going to be a real challenge.
Now, you touched on something I think a lot of people aren't necessarily aware. A lot of people deal with their insurance at the point of care. It's not something folks are worrying about in their day-to-day. It's when they're actually sick and standing in your office and they want to see you that they kind of worry about the fact that they may or may not be covered. How much do you see your staff being in that role to educate the patients ultimately where the issues are arising?
I think if we have PhDs at the front desk, the 600 practices we have, it would be great. It's a huge challenge to educate people. It's not only for the exchange. You have dozens of other plans in Medicaid and Medicare and commercial. And each of those plans has 27 different plans within it. It's a challenge, and it's really difficult. Technology solutions may help a little bit, understanding what the benefits are, what the patient's responsibility is. The only good point is that I think in the first month of the exchange rollout in January, we had only 4 hospital patients admitted to Well. So as you heard a minute ago, access to this ramp up very slowly, but will ramp up, and I don't think we're prepared at all.
Dr. Orange, your final word, panel?
I just would agree with Dr. Wolk, and I think that it's going to be a significant challenge. The one study that I'm aware of this was in Oregon, when they did expand healthcare delivery there. What they actually found was that utilization went up and costs did go up. So there was going to be a change in not necessarily the direction that people had expected or hoped for.
Thank you. So this concludes our first panel on the expansion component. We're now going to roll into a networking break. We will resume at 8 o'clock. Dr. Wolk will provide a quick presentation on the impact on quality and reduction of costs at the Cornell Providers Organization. And then we're going to roll into the second panel, which I know all of our panelists are especially excited about. How are they dealing with this quality issue? And what's the impact for each of you as patients, and then again for your organizations. During our break, if you have any questions that didn't unfortunately get asked but would like to get answered, please feel free. We are all certainly available for that. And I'd love to try to address them in the second panel. There are, of course, refreshments provided by Emblem. Thank you so much again for hosting us, and we'll resume at 8. Thank you.
I thought the panel discussion and the questions from the audience were
so germane that what I'm going to try to do is blast through this in 12 minutes or so that we have at least 50 minutes or 45 minutes for questions from you folks and discussion from the panel going forward. So this is the influence on our physician organization, which may be different than any other physician organization, because if you know one, you know one. And that's a picture of New York Presbyterian Hospital on the left, and the corners are Memorial Sloan Kettering and Rockefeller. So basically, just as a brief description of who we are, we're a 1,100 member faculty organization. We're fully employed by the medical college. We're not employed by New York Presbyterian Hospital. We're not a PHO. We are employed by the medical school. Single tax ID number permits us to negotiate contracts for all our faculty members, and our faculty members now include 142 new members of our organization from New York Presbyterian and Lower Manhattan that occurred last July. In contrast to other organizations, we are low in primary care. It was much lower a few years ago. We're up to 8% of our faculty is primary care. Our revenue is mainly commercial, which is more than it was 10 years ago, from 50 to 70%. It's exaggerated. It's not our book of business, because our book of business is far higher for Medicare and Medicaid, but the fee structure schedule for commercial business, as you heard before, is higher than in Medicare and governmental products. Again, we are 97% fee-for-service, and if you asked me if I predicted that 3 or 4 years ago, I would have said we would have moved in the direction of a fully integrated organization, with an accountable care organization, and we're not there yet. We are in Manhattan. It's a different part of the world than Boston and maybe even the Bronx. But nonetheless, only 3% of our revenue comes from pay-for-performance or shared savings. And we do have shared savings, as mentioned, for primary care. We have no capitation, nor will we for at least 4 or 5 years, I would predict. And we were not involved in an insurance plan as North Shore and maybe Mount Sinai Medicare Advantage might be in the future. Just a mea culpa, in red there, our costs are not sustainable. We recognize that at our institution. We need to clinically transform what we do. Our contracts are high, both for the hospital and the physicians, and our utilization is high and needs to be lower than it currently is. And quality of care, although we're measured against others in all our accountable care relationships, while we're better than most folk, our care is still uneven when you look at the quality parameters we're looking at. So my favorite philosopher, Yogi Berra, said it's hard to make a prediction, especially about the future, but I think in this particular article in the Harvard Business Review by Michael Porter and Tom Lee, they made the right prediction here. When they said in healthcare, the days of business as usual are over. We at our institution agree with that. We need to provide more value than we're providing in order to be in a stronger position in the years ahead. So I don't know how many people have seen the ARC, or Russell Crowe fans, not too many that I've met. But nonetheless, this is the Obama ARC, and as you heard, the numbers are enormous, and in the background, to be announced soon, are 2 elephants in a boat, and I won't tell you what party I vote for. Just want to enforce one point made in the original talk. The original discussion was about improved access of care. I just don't want to have anybody lose the point that the Affordable Care Act had very significant delivery system accomplishments. Now, some have been mentioned, but just to think about the fact that the Affordable Care Act had very significant starts with the ACOs that you heard about, all the quality bonuses and stars in Medicare Advantage, reducing preventable hospital readmissions, and I think overall we're down to 17% from 19% only 5 years ago across the country, discouraging hospital-acquired conditions, and I think one of the best parts of the law is the Center for Medicare and Medicaid Innovation and the grants they are giving out to try to find how we can best do healthcare delivery and what the best payment system might be. Now, this is a biased slide because it's made up by the Medicare Trustee Report of 2013, and it shows the pre-ACA projections and the 2013 post projections. And while many people think the ACA had some impact on reducing costs, I think those of you in the audience who read health affairs on a regular basis will understand that the recession and access to care and other issues also played a major role in the last few years. So here we are with two canoes, fee-for-service, which just sunk. I wonder if I can get that back, but we'll try to do it again for those who missed it. About 3 years ago, we believed that we would be in the value and risk canoe. We didn't want to have two legs, one leg in the fee-for-service canoe and one leg in the value risk canoe, and the canoes spreading out. That's a very uncomfortable position to be in, but nonetheless, we are moving very slowly away from that first fee-for-service canoe. But we recognize we need to, and we need to move from volume to value. And as other institutions have done, as we move from left to right, we move from low risk to high risk, and we also move from volume to value. And we have been doing fee-for-service for 5 or 6 years, shared savings for 3 or 4 years, pay for performance pay for performance for the last 4 or 5 years, with shared savings in the last 3 or 4 years. Now we're trying to make sure we don't get penalized by CMS for PQRS measures. Thankfully, we're moving into bundled payments, hopefully with Medicare in the near future. We will have a formal ACO catching up to our friends at Mount Sinai in January. And as I mentioned, we'll never be in capitation, at least for 5 years, nor have an insurance product. Bundled payments, I think, really give a great opportunity to control costs. And if you remember the original ACA bill, so much of the savings to pay for the ACA was in the bundling of payments and the savings thereof. Our whole approach at Weill Cornell is aligned completely with the triple aim of Don Berwick. If anybody votes in Massachusetts, he's running for governor. We'll have to see how that works out. But basically, the triangle is better health. Are you in Massachusetts?
I'm from Massachusetts,
Who
and
are you
I'm
voting
voting
for?
for him, and I saw him in January speaking, and I'm voting for it.
Great. So I must admit, I said $100 and even though I'm apolitical also. Anyways, better health and population, lower cost and lower unit cost, and better care for individuals and more patient-centered individuals. So all our activities are geared at one of these, if not all of these, parts of the triangle. And let me go through a couple, because some of them are a little controversial. Population health was mentioned before, and although there was a mention that doing preventive care is important, the question is what is the return on investment if you spend a lot of time on 50% of the population who consumes only 2 or 3% of the cost. So our approach really is to try to figure out which patients in the 10% of the population that consume 65% of the cost should be addressed. And that's not an easy issue to figure out, and we're struggling with that at the present time. What we're trying to do is do predictive modeling, using a number of indices, trying to stratify patients by risk. Those high-risk patients who are consuming a lot of dollars, we'd like to give them more attention and understand that care goes on between patient visits and not just the patient visit. And we're trying to educate those folks. And we're trying to educate ourselves. We don't know a lot about ACOs, and we're trying to participate in the Medicare and any commercial accountable care relationships we can get into. It was mentioned before again about population health, and this slide may or may not be true, and everybody, it'd be fun for the panel to discuss this going forward, but population health advocates, as I did 3 or 4 years ago, embrace prevention, de-emphasize treatment of the sick in favor of avoiding sickness. But the problem that we all have to face is what's the economic reality? And the economic reality is that it's all about treating the sickest patients more efficiently, decreasing utilization for those patients, because that's the way that we can really cut down on some of the costs, at least at our own institution. We're also working, and nobody's mentioned this yet, with medical homes. We do think that there's a future here. However, the evidence still is iffy at this time. I think as they evolve, they'll be extremely valuable. We're actually at Weill Cornell applying for NCQA accreditation for specialist center medical homes in cardiology and in ophthalmology. And I think maybe the medical neighborhood, as that evolves, may be the most important and best approach. We're also trying to address variations in care, which if you remember in the ACA proposal, the variations in care cost significant dollars, and there were significant savings if we can reduce variation in care. And this slide, from left to right, just demonstrates the number of patients getting imaging studies at the time of their presentation for acute coronary syndrome, and it varies from 4 or 5% to 40%. And there's no rationale because at all these institutions, the same number of patients went through revascularization and meant nothing. So we want to know where is advanced imaging appropriate to use or not appropriate to use. And so one way to do it is we have good guidelines in medical literature. In cardiology, we have very good guidelines that tell us what we should be doing for some sick patients and for medical technology and for diseases like bypass. But we're not good at looking at some of the low-value activities. And thankfully, the American Board of Internal Medicine has started this project, Choosing Wisely. I think a lot of our institutions are adopting it. There are now 60 specialty societies who have built from the bottom up opportunities to get the low-hanging fruit. This is American Academy of Dermatology. Don't prescribe oral antifungal therapy if you don't do a confirmation. And every society has that, and we're trying to get our chairs of medicine and chairs of dermatology and other chairs to adopt some of this. In addition, we're following the American College of Physicians patient-centered list of low-value activities, and this is an educational opportunity for our patients if we give them a to-do list, and if we also give them a two-question list. And a to-do list is what we think they should have for screening, blood pressure, cholesterol, and colon cancer. And the question list with your physician to discuss is why do you need an imaging test for non-specific back pain, or an imaging test for headache, or antibiotics for sinus infection. So we're trying to get rid of the low-hanging fruit and the low-value activities that we have historically performed. In our transformation initiatives, this is a list. The black is what I think I've talked about. I would like to go to the bottom two topics because they're really important. One is mental health. We are trying to work with our hospital, with our physician organization, and with the payers to form a three-legged stool to provide adequate mental health access. We do not have any mental health access for those patients who desperately need it, namely those patients with multiple comorbidities who also have psychiatric problems, who are in and out of the hospital and in and out of the doctor's office, and we're trying to form a small mental health team that will handle some of these patients going forward. We also think the better quality we have, that cost should follow the quality. And so we encourage our physicians to get into data registries, dashboards to measure how well they do or how bad they do, and also, as many other institutions, adopting more decision support tools for advanced medical imaging, et cetera. There are challenges ahead, depending on whether you're in the physician community, the hospital community, or the payer community, and this is just a slide on the left, the projected discharges from hospitals, which will decrease rather dramatically over the next 7 or 8 years. This is also a challenge as we go forward. How do physician groups or hospitals or payers handle the situation where there's going to be a shift in the payer mix away from toward government reimbursed patients as commercial enrollment declines by 19%, Medicare grows, Medicaid grows, and health insurance exchange, as we've all heard, enrollment grows, and this comes from Deloitte. I actually talked about this before because I think health insurance is not health care. It's a very important point, and I don't think we need to go through this once again, but I'm very concerned about narrow networks for a number of reasons. No out-of-network benefits. How do people get cancer care, cardiology care, renal dialysis, transplantation, etc. Lastly, one of the other things we're doing at Weill Cornell, this is the last slide, is we're establishing health policy
leadership fellows. And basically, we're doing 5 to 8 a year, and we're trying to train individuals who will be develop innovative solutions to integrated healthcare, to the ACA, and to provide better value-added care. And so the program, the application rate expired April 4th, but we have 19 candidates, and we'll have 8 of these fellows in the 3rd year going forward. And I think the shortest commodity, really for healthcare reform, probably is physician leaders, among other things, going forward. So we have a bloated, as a cardiologist, this is a perfect slide for me to end. We have a bloated healthcare system. We have a bloated Weill Cornell physician organization. And although I hear a little bit, I think the president here is hearing reform, so I'll stop there. Thank you.
Thank you, Dr. Wolf. I'll certainly leave this up here as our panelists come back to the front so we can continue the conversation. You touched on so many really interesting things that Cornell is doing, such a progressive organization trying to get in front of the impact of the reform measures of the Affordable Care Act are causing us to think about. This is tough. This is hard stuff. This is complicated. I mean, Dr. Wolf, when you went to medical school, did you think you'd be in the business of population health management?
No, I just wanted to be a good old practicing doc, take care of patients, which I still love to do, and I still want to do, even though I'm doing managed care, and I maintain the practice at least 1 day a week. Because if I gave up that practice, I don't think I would have fun.
It's about seeing the patient. Now, Dr. Cornser, same question for you. You went to medical school. Is this what you thought you'd be getting into? Did you think you'd be saying to yourself, man, I got to start worrying about what the patient is doing outside of the 4 walls of my office?
So it's actually interesting. Even when I was a resident, I think that was just, I graduated in 2008. So they were just starting to think through questions of population health. I was at Mass General, and they were just starting to do risk-based contracts, and MGH was leading up to pioneering CO, thinking like, how do you deal with the most challenging patient populations? But certainly it wasn't part of my medical education. And even today's medical students, I don't think the curricula yet really address how people can think thoughtfully about delivering care to large populations of patients.
So much of our population here in New York City is driven by small practice providers. Our primary care community is predominantly situated at the moment in small independent practices. In order to start tackling some of these issues, like I said, are outside of the 4 walls of their organization, how do they, as a small practice provider, how do you even begin to start thinking about some of these challenges? Well, what are some of the things that you think you would need? And I'm going to go back to Dr. Wolf here.
Well, I think they're going to have to be integrated in a bigger kind of organization. And there was one slide that we didn't show that showed there were 5 organizations in Manhattan, whereas there was 15 only 8 years ago. So we're down to Mount Sinai, Weill Cornell, and NYU, and 1 or 2 others. And I think, and all of us are going out and developing bigger networks so we can do population management and take care of all the patients that will be in our accountable care organization. So we're all going to have big networks. We're all going to need physicians in different geographic locations. And so it's a great opportunity to have some of these folks join our individual respective networks at our hospitals. Of course, how they join is a different matter, whether they join as a full-time employed physician or this is voluntary, but I think they're going to have to participate. But to be integrated, they need electronic medical records, which most of our voluntary attendants at our institution do not have or do have.
I think we can help with that.
Right. And we have to communicate. We have to communicate with them. They have to measure quality as we're doing going forward. So it's a big onus on a bunch of physicians whose main goal is to see patients.
So it sounded to me from our previous panel that for the plans, and correct me if I'm wrong, this is what you'd like to see. You'd like to see consolidation of all these providers across the city here into larger integrated networks because they'll have the resources and they'll be able to be more efficient. Is that a misunderstanding on my part?
I'll start. Things are never so simplistic, I wish. I think while the organization into entities, whether it's ACO or whether it's PCM, patient-centered medical homes, etc., is certainly in theory a great direction of change. Every year you afford them more capability in an organized fashion to improve care coordination, data gathering, population health management. That smaller practices just is never really going to be ever equipped to do so. However, sort of economics 101 goes back to it. A healthy ecosystem is always is a good thing for plans. So while we'd like to see consolidation to a certain extent in the context of ACOs, more accountable care, what keeps me at night too is this really going to ultimately deliver the triple aim, right? Especially around cost. So if you look at our national expenditure data, healthcare trends generally have stabilized or plateaued in terms of utilization. It's the unit cost that's still an issue. And so to me, think about it, if you have bigger entities who are now able to have higher bargaining power, I just think about how effective then are we really at the end of the day able to manage cost, and depending on which perspective, society's perspective or health insurance perspective. So that's the question I have. I don't have an answer. Certainly, folks like Regina Herslinger echo my thought. I don't know if you follow her. She's one of these, had a lot of credibility at Harvard predicting trends. She certainly contend that ACOs and PSAN are possibly is not the deal and all and possibly fail because some of the reasons I just cited and many others as well. So I think yes and no, the answer.
Now, Emblem, having been in the market for a while now, is in a tough situation in some cases where you have contracts with providers, and sometimes breaking those contracts is difficult because you're then disincentivizing the patients who are on those providers' panels who are ultimately your client. Now, AlphaCare, being a new entrant to the market, is in somewhat of a unique situation in that you guys are able to sort of pick and choose at this point in time who are some of the providers that you want to have in your system. So I'm curious, are you looking at the small independent practice providers in New York City, or are you thinking to yourself, you got to line up behind these larger integrated delivery networks?
I think it's actually both. I think so. There's actually some in the public space. There's some regulations in terms of having a sufficiently large network. So actually, when we were building our network just to meet the regulations under FIDA, we needed to have a certain size network. We needed to partner with the Mount Sinai's of the world. We needed to partner with the mom and child primary care physician practices where our members are going. Because our members, as some of you may know, have multiple chronic conditions, live below the poverty line, 40% of mental health issues. These are individuals who really need community support. So, on the ACO, integrated versus not, I think the jury's still out. I think it depends. It's always easier to sign one contract than many. But ultimately, I think from our perspective, it comes down to who's going to make the best partner, who's going to actually care for our members, who's going to be part of our integrated care team, and I think that those are the people who we are going to partner with, and whether the network gets narrow or not narrow is going to be defined based on whether we can deliver the care and provide access to our membership. But I actually wanted to make one other point, because we're talking about network in a very narrow way, no pun intended here, because we're talking about clinicians. We heard a little bit about mental health, but we also heard about some of the community-based organizations, there's public dollars going towards, and as we shift from a reactive-based healthcare world to a preventative, we actually need to be thinking about those social supports in the community that are non-clinical in nature, but actually very clinical because they're precursors for you being able to address the clinical issues. So I think, I'll make one point on AlphaCare. When we think about the network, we think about, partnering with the housing authorities in New York so that when our members get out of the hospital and they don't have somewhere to go, we can call up someone and have them there. We think about nursing homes, which has sort of been a marginalized portion of the ecosystem. How can we help those organizations who can do a lot more become more value-added members of this broader network?
Now, you brought up a good point here, which is with the accountable care organizations. Now, there's a couple different kinds of accountable care organizations, at least present here in New York City. You have those that are being run by large institutions like Mount Sinai, Montefiore Hospital, Health and Hospital Corporation. You have some that are run by large healthcare organizations that aren't hospitals, like Pro Health out in Long Island. But then you have a bunch of groups of physicians who got together, who put an organization of providers into an accountable care organization who don't have the traditional infrastructure. In the most simplest of ways, the doctors who work in the ACO are not employed by the ACO. They're all independent business people who are self-employed. Now, Dr. Cornitzer, you work at one of these kinds of accountable care organizations, so taking off your Mount Sinai hat and putting on your Balance ACO hat, how do you align all of these disparate providers? I mean, Cornell has a number of doctors who aren't even on EHRs, and they're all forced to, they're all working in the same location. You oversee a group of providers who have very limited incentives or penalties, depending on how you look at it, to try to align and to try to adopt some of these population health management tools, which we're hearing the Alpha Cares and the Emblems are looking to.
So, one of the core principles of the ACA is the idea of trying to get doctors to work together so they can develop networks and provide really high-quality population-based care. Now, there's a couple of ways of doing that. You can either have a Medicare Advantage plan where they do the contracting, they select the physicians to be in their networks, or you can give physicians the opportunity to band together and try to meet those same goals in terms of delivering high-quality care and also intelligent utilization of resources. So the group that made a Balance ACO, so Corinthian, which is mostly Upper Manhattan, in the Bronx we had groups like Essen, in Queens we had a group called Excelsior. So these are large independent physician associations that already have some sort of infrastructure. In other parts of the country, for example, in the Midwest, you're having groups that don't even have the infrastructure and the IPA that are used to doing some sort of contracting coming together. We were fortunate that we had an IPA, so people were used to dealing with some sort of infrastructure. Most of them had an EHR ready. They were used to having quarterly meetings. And the big question is how do you get physicians to engage with one another? How do you get them to engage in a quality agenda? How do you also get them to deal with utilization? So if you get a group of doctors together and one of them happens to be a subspecialist whose practice is a significant outlier in terms of their utilization, that's going to be something that's going to hurt that entire community of physicians who are banding together and trying to do accountable care. So that's the incentive process. And hopefully the take-home message that the ACO members, the individual physicians got from their leadership is the message that right now, I believe the most recent number, there's somewhere around $580 million a year to Medicare annual spend. The majority of that spend right now is going to inpatient services. If you take a look at the primary care providers out of the community, they're only getting a small slice of that pie. And I think the government has been pretty clear that we as a country can no longer afford to increase the amount of money and the percentage of GDP that we're spending on healthcare. So that pie is not going to get any bigger. So the only way that primary care providers can continue to survive in this changing and evolving landscape is to be able to go into these visionary relationships where they have an opportunity to see some benefit for all the work they do in terms of care coordination, in terms of quality.
So do you think ACOs like Balance and like the other independent physician organizations who come together into an ACO are a way to keep small practice physicians independent?
So my own biased opinion is the days of...
You're not a biased opinion. You work with both Mount Sinai and an independent provider ACO. Mount Sinai is rapidly acquiring practices across the city.
I mean, yes and no. I mean, the physicians who are within Balance, all of them, for the most part, belong to some sort of IPA or large practice. So they've already made the decision that they're going to have some sort of relationship with a larger entity, whether that larger entity is an IPA, whether it's Mount Sinai, or whether it's a health insurance company that's launching its own product. It doesn't really matter. The idea that no one can be an island unto themselves anymore and succeed.
So I'm curious now, all of you here are patients. Everyone here indicated earlier they have health insurance. How is this impacting you? And I hope you know the microphone is certainly live. If you have questions about this, what will this impact of the potential loss of independent practice physicians in your community to larger organizations? Is this something you guys are concerned about? So please, if there's any other thoughts that come up, feel free to come to the microphone. I'll certainly turn the direction to you. So I hope you will certainly ask us questions. I'm curious now, going back to you, Far, what are your thoughts on these different payment models in terms of where we're going for the patient experience?
Well, I think the fundamental thing that everybody's focused on is this whole idea of quality and also taking care of the kids. And I just want to talk a little bit about population health for a second. You spoke about that. Some of the companies that we have engaged with at one level or another are focused on population level. And one of the things that they're interested in is how can they manage patients at the population level, not only when they're in the physician's office, regardless of whether the physician is independent or part of a physician organization or a partial group or whatever, and also their individual decisions that they're making on a daily basis that influence their health. And so this focus on prevention and quality from a population health perspective is increasingly boiling down to, and I spoke about this before from a goal perspective, but the individual decisions of patients, especially the patients that are highest cost patients, right? There's a big debate right now, for example, in the wellness space. Wellness programs are actually working there. And Rand actually came out with a study that showed that the wellness programs that have the most impact are the disease management programs. Right, for the sickest patients who have diabetes, who have, potentially, kidney disease, all these things, and actually working with their physicians and working with their other care teams to actually get them to take their medications, get them to engage in lifestyle modifications, et cetera, that has the biggest ROI, right? And so if you think about what the individual patients have to, or what we're focusing on, a lot of attention is being paid to the most expensive patients. And how do you actually get those folks to do things that are going to decrease costs over the short and long term? And from a physician perspective, and I'm sure you've seen this as well, the unfortunate thing for physicians is that they're being put into the position to manage that and be responsible for that from a quality perspective when they honestly have very little to do with those decisions. So the patient comes into the doctor's office, and the doctor says you need to take your meds, you need to do this, you need to do that. They walk out of the doctor's office, they don't do anything. Mm-hmm. So you have a situation where you've got the patient is the one really driving the ship, but the physicians are the ones that are being held responsible for that. And so we need to figure out how to balance that.
Here's an excellent point.
Hey, how you doing? Jack, I work at MedStarter. So full disclosure, I wanted to get a yearly checkup. So I went on Zocdoc, booked a doctor. The next day, pretty much had an appointment. They drew my blood. Is that the kind of thing? And everything's fine. I mean, is this the kind of ease of access and consistent behavior that you want every person to do? And if so, is that going to be affordable? And is that the goal of this whole change the way people think about health? Or is that kind of too much stress to put on the system?
So I think I'm understanding there are sort of two questions here. One is, are we going to be able to see a greater increase in access to care?
Yeah.
And the second one is what are we doing to position ourselves with tools and potentially technology in order to make not only access to care possible, but also sort of facilitate the actual process in which you can manage one's own care and interact with all of the aspects of the care continuum?
Yeah, that's great.
So I think it depends. I think it depends on the segment of the population. If you're a young, healthy guy, you look at, who is familiar with Oscar Insurance? Okay, for those who aren't, so Oscar Insurance is a startup health insurance company in New York, really by a slew of technical guys, and they've got, they're on the exchanges, and they're really, I would say, surveying a very healthy, young, tech-enabled population. And they have an application, so if you sign up for them, you can get Teladoc on demand. You can have free generic drugs. They will give you chicken soup when you get sick, right? So you may say, oh my God, well, this is a lot of money. And they may say, well, wait a minute. If our members are calling Teladoc, that means they're not going to the hospital. I mean, the jury's still out on the medical cost side, but that model might work for them. I'll give you the complete contrast. The population at AffordableCare may have a flip phone, probably has a flip phone. Some may have smartphones, may or may not have internet, may not have housing for certain portions of the week. Definitely have mental health issues. So frankly, if we could get them to go do that, we would be incredibly happy. So our challenge is very different. Our challenge is around how do we find our members, how do we engage our members and partner them with where they're at, and how do we make sure that we have that contact? Because our issue is our members don't seek the care when they need the care.
Dr. Wolf, I think you want to chime in here just to give a slight perspective.
It's really interesting that a healthy young person gets an appointment one day, but a patient on Medicare and Medicaid has to wait 3 months. So my question really is, I don't know what your insurance is or who you went to, but if there are some advantages of the group seeing you at a timely way like that. But I think my main concern is access to care for others, older people, Medicaid people, exchange folks. I don't know if it's going to be as easy as you're implying.
Yeah, it was Oscar for full disclosure, it was one of the exchange.
When I was
Yeah, Oscar, yeah. Now, I'm curious here, on the concept of access, the whole concept behind patient-centered medical home, where you have an enhanced reimbursement for Medicaid patients whose providers have been recognized as a patient-centered medical home certified entity. One of the key components of PCMH is access, increasing hours and the rest of it. Some organizations, I understand, are in the process of opening more urgent care centers across the city, providing more retail health centers like CityMD, CVS, and Rite Aid. Apparently, have both announced that they'll be now offering clinics for a large integrated system, either Cornell or Mount Sinai. Is this a direction that you think will go in order to address, Dr. Wolf, your concern about how do Medicaid and Medicare patients get that access when they need it?
Well, CityMD is part of the wild Cornell approach. It's basically they're in our IPA. And what we want to do is we want to decompress our emergency room. People come to the emergency room and it's $1,000. They can go to CityMD and see in 5 minutes for a sore throat for $120 or something like that. They get a CBC, a throat culture, chest x-ray if they need it. They get an x-ray of their arm and be sent to them. In case they need it, they get referred downstream. So I think these urgent care centers, where appropriate, should be able to play a role. And I think if any individual at night or during the weekend in their own zip code, wherever they live, knows where their urgent care center is, we can save a heck of a lot of money going forward.
I have a very strong viewpoint about that. I don't disagree. I think urgent care centers have a place in the delivery system. I don't know how wide that space is going to be. I think recently Health Affairs had an article looking at Medicaid population utilizing ER and the ER utilization in New York City. And it dispelled a lot of very traditional viewpoint about Medicaid and ER use, where we think it's because they're not engaged with the system, they can't get access, that's why they go to the ER. The data showed a little bit of that, but most tellingly is actually the majority of Medicaid members or patients who go to ER, they go there because their needs have not been met. They are high utilizers of office visits as well as outpatient services. So it's not so much about engagement or disengagement. You know, this is traditionally, it's a myth for the most part.
It's about convenience.
It's about needs and about that a lot of these folks have high acuity of care that may perhaps need to be seen more often in the outpatient setting. So to your point, I think urgent care has a place. I don't know how big of a place they can, and I don't know how successful in totality they're really going to be able to decrease the unnecessary ER use in certain segment of our population. I'm not saying no, I just don't know.
So, to the audience, I think we have a question.
Okay, so I asked Dr. Wolf this during the break, but I wanted to hear your perspectives. One of these issues that we're talking about, prevention and patient education, I feel can be solved with a lot of the new technologies, that these startups are developing. What are you guys doing as far as maybe reaching out to these startups or seeing what technologies could be adopted and which ones could be useful?
I'll start. One of my many roles at MLOP is to bring in innovations. I think technology, and I believe Michelle had said it, to me it's not a solution, it's an enabler to a solution. You still have to engage people, you still have to have a programmatic approach, and then deploy your technology, to me, is about using technology to scale something that you may not be able to do so much like in a high-touch manner. So technology, again, to me is a tool and not so much a solution. Yes, are we looking through, and I believe I have a partner here right now, and we're going to partner with leveraging technology as a tool. But at the end of the day, though, to me, is you still have to have a good care model or care program that makes sense, that is of value to people, and then deploy a right type of technology to scale it. right, or piloted. And technology is great for tracking and evaluation, in my opinion. Not so much engagement. You know, if you're using technology to engage, I'm not a strong believer in that. But if you use the technology to scale, to track, evaluate, and help you do more than what you can in person, I think that's where we are today. So I don't know, you guys have others.
Yeah, so I actually definitely think we could use technology to engage. So, you know, in Affordable Cae Act, we've done a bunch of things. So we're definitely very embedded in the New York community with some of the accelerators here, Blueprint Health, Startup Health, and bringing them in and starting to understand what they're doing, what problems they're looking to tackle. You know, getting them involved with our clinical team if it has something to do with that, our analytics team, and figuring out what that looks like. Because I think for like I think I mentioned this earlier, for innovations and for these startup companies to be successful, they really need to be adopted. And so you need to take a risk and you need to help them get the data that they need to scale broadly. I think in terms of the way that we think about the use of, I would say innovation broadly, it's actually that, you know, IORA Health or One Health Group, for all intents and purposes, are innovations. They're just more in a clinical setting, and CityMD is another one. So I'm actually very pro CityMD. Anytime that you can have a bricks-and-mortar model where you can provide access to your members to go in, I think it's a great thing. And it's just about the education component that we're really missing to help our members navigate that network that we're trying to build. But I guess the technology is about understanding what's out in the marketplace, mapping that to the needs of our organization with the goals of, you know, improving quality, reducing cost, and enhancing member satisfaction so that we can all have sort of a dot-to-dot type of experience, so to speak. And then being very thoughtful about where we go first, because everyone wants to adopt a new shiny thing, but at the end of the day, if you can't really show an impact, then that's not going to be well received, and you're not going to get the buy-in.
So, you know, technology happens to be something I think about every day. One of the things that I've been talking to folks about, local startups and within health organizations, is actually flipping the script a little bit in terms of how we think about technology. So the traditional model is to say, you know, get some shiny new objects, get a whole bunch of people to adopt, deploy and measure, right? But in health context, adoption is very difficult because you've got a highly stratified, right, group of working with people who are, you know, poor. Right. So the point that I'm making here is I think we need to move away from kind of the engagement approach in terms of trying to get people to do stuff to actually building out technologies and innovations, whether they be analog or digital, that are actually embedded within people's communities. So what I mean by that is, you know, the embeddment strategy is the CityMD, right? It's the, you know, simple technology of using someone's flip phone to connect with them via SMS, right, at the time that they need that information the most. So the embeddment strategy requires having the data that predictive analytics, like what kind of things that you're doing, to be able to make decisions about when technologies need to be deployed, right? And inserting them within people's lifestyle and the way that they work and do things every day in a way that's largely invisible and not disruptive to what they're trying to do, right? So if you're dealing with someone who's an older patient, right, where you're trying to get them after they've been discharged from the hospital for heart failure, a simple execution if they can't walk down the street because they're afraid of being shot, right, is to bring in, subsidize some kind of telehealth sensing technology, what they've done in Baltimore, and actually collect that data from the patient in their home, engage with them in their home, and use the dollars that would be ordinarily used for that. That's embeddment, right? So this embedment as opposed to engagement concept, I think, is a powerful one that can help people to overcome some of the kind of traditional limitations they've put on technology. So it's not about trying to get people to adopt like a new app, you know, or use Oscar, or, you know, do what you did, right? Because not everybody's going to do that. Most people don't care, to be frank. But when they're in that place where they need that care or they're engaged, that's the time to deploy the intervention to do that. And so the reason I'm talking about amendment a lot is because they're learning this in the readmissions game, right? Readmissions, they're trying to reduce readmissions, and what they're doing is they're using data analytics and using targeted technologies to get people to not reenter a hospital or figure out what's going on in the hospital, so people aren't getting infections and things like that. It's all within the continuum of care, as opposed to these kind of alien things you're dropping into people. So, you know, if you kind of remember one thing from what I've said, it's embedment, not engagement, and how can we get it embedded into their lives in ways that are invisible and make sense. So that's kind of what I would say about that.
I think that's a really interesting point, actually, just to highlight a little work that the Department of Health is doing here in New York City. We actually piloted a program with faith-based organizations recognizing just that ultimately folks sitting in church on Sunday are more likely to be paying attention to things that ultimately we are unable to get penetration through via things like text messaging, email alerts, and the rest of it. So by putting some technologies and training the tools of lay people at the churches, we're able to kind of bring that message out. We'll start to see an impact on things like blood pressure control, where these congregations have someone on Sunday saying, now after the sermon, I want you to go over here and this retired nurse is going to take your blood pressure, and then they enter into a computer program we developed for them so they can actually track and see how is their congregation doing. So rather than trying to put technology in the hands of everyone, putting it in the hands of key stakeholders. And I want to turn now, actually, to a couple of questions set up in the audience.
Hi, I'm Dr. Kala, I work at the Commonwealth Fund. I was interested in what you were saying about investing in social support for your high-need investigations. And I was wondering if you could speak a little bit to how much money you invest in terms of your overall strategy, and if you've seen any return on investment in that in terms of generating buy-in.
So I think we put some skin in the game and invested mainly in care management approach. So we have a 5-year plan. It only provides us with a modest number of care managers. But I have to really praise all the commercial payers in New York City, including Emblem, who have provided us with the funding for additional care managers. And so we have care managers who are nurses, social workers, psychiatric social workers, and we're trying to help some of these folks either get to the hospital or get back with dollars or money or cab fare, try and have them understand how to get the prescriptions, try and get the timing of the taking the medication set up with some smartphone apps. But it's a lot of hard work on the basis of a care management team that's really dedicated in trying to help these folks out. But what we're lacking is mental health access. We have none. There are more physicians in the community than we have who are willing to promptly see a patient desperate for needs.
I think it's a great point. Well, you touched on something really interesting here, and I've had the fortune in my role in the health department to actually sit on a number of panels over the years. And it's usually been a very contentious relationship between the providers and the payers. In fact, we tried to put on an event a few years ago that didn't go so well. We ended up having to disinvite one group of them. And I think what's so fascinating today is that you're starting to see these partnerships build between what have been historically an adversarial relationship, where you have payers and providers coming together and saying, how do we solve this problem together? Because with payment reform, we're starting to see this impact everyone across the board in terms of the bottom line. I think the example of the care managers that are being provided is a really good one.
Hi, this is Alicia Davis from New York City Department of Health. I had a question about, I guess, the cost of the plan for healthy individuals. So the plan costs about like $300 a month, and the deductible is $3,000. What is the incentive for, I guess, healthy patients on those plans to get on the plan, besides the punitive measures? Because essentially, most of their care will be coming out of pocket if they don't reach that deductible. So kind of like what benefits do they get from being on the plan? And really, besides punitive like tax measures, like what's their incentive for signing up?
Bingo. That's why the average age of sign up is 40 years.
You can walk into the city, you can walk into City MD at any time and pay $100, $90 out of pocket to see a doctor. You can pay Tylenol, less than that.
There's direct contracting, I believe, $90 a month, in which you can have unlimited access to office space. So I think you're right. I think we need to create solutions, including not just real programmatic solutions that really attract healthy people, but also messaging solutions as well. I think it's a culture shift in the nation, right? We should all be in it together. We should try to help each other. Whether you, I think it's a paradigm shift. We're not Europe, where we don't operate under that democratic socialistic system where I should help the guy next to me because he's obese and he's out of work. Why should I pay for his share. I think until we have some of that national paradigm shift about who should we take care of, and is it just us, or I think it's very hard.
Thank you, Lisa. Any other comments on this from the panel?
So in the few months, opening upon, I work with Home Health Program, in the few months that you have to sort of assess the utilization data in people signing up and deciding who will be part of your narrow networks moving forward, are you reevaluating how you're assessing performance? Like, for example, New York Times was made as a doctor that talked about a taxi driver patient who's diabetic and not doing any of the lifestyle changes or behavior modifications that she's recommended. But she's considering her own gains even if it doesn't reflect in her performance.
So let me make sure I understand your question. Your question is really how fair or valid, right, for assessment? Because maybe they're taking care of a higher risk population based on geographic demographics or occupation. Is that sort of?
Are you sort of rethinking how you evaluate what is a high-performing doctor?
No, I think it's a really fair question. I don't think just like any modeling tool, whether it's predictive modeling or any assessment tool, it's very difficult to get it right. So I think what we tend to try to do is utilizing a tool to manage some of the outliers, because the truth is if you're 2.5 standard deviation out, I think there's a story there. So you have to really dig deep into what understanding the outliers, because they're just, as a delivery system, taking care of the super sick, or they're outliers because there's some quality issues. To me, that's really outlier management is where I think the tool is past that. It's not so much deciding whether someone who falls within a 2 standard deviation is better or worse in quality than one. It's very difficult to do, even with some Medicare tools where you can know sort of the relative risk of your membership. It's still very difficult. So until you're able to really risk adjust, right? And not just by diagnosis, you should risk adjust by demographics, race, ethnicity, language, cultural, religion, all that, which we don't have access to as far as to be sophisticated analytical tool. It's very difficult. And sometimes we do go and have not focus group, but we do ask our providers, partners, downstream, upstream, what do you think about this group or this person? Our data is showing something, and is it cooperating with your sense about the quality?
Thank you, Councilman. So I think we have time for just one last question from the audience here.
My name is David Meyer, I'm a physical therapist at a hospital for special surgery. It's close to Dr. Wilk. You mentioned briefly about reducing unnecessary testing, such as MRI, for instance, for non-specific back pain. As a physical therapist, a doctor of physical therapy myself, my colleagues, on your end, as far as direct access to see a qualified provider, what are your thoughts, and this goes to the whole entire board, on maybe helping to reduce the getting to a physical therapist for non-specific back pain, allowing direct access for other qualified healthcare practitioners?
A couple of answers to that one. One is if you look at some of the three articles in the New England Journal of Medicine, in 30 days, 99% of people are better whether you go to a physical therapist, a chiropractor, get aspirin, or have surgery. So they're going to get better. I think the thing that we need to do is educate doctors about guidelines. And that's why choosing wisely is such a wonderful approach at low-hanging fruit. It's just emphasizing the fact that MRI is not the first thing to do, and that alternatives as physical therapy, or even acupuncture, or even rest, or even exercise, or even non-steroidals are under approach.
Thank you so much. If I could invite Alice Farrow back up to the podium here to close us out tonight.
I just want to thank everybody for coming tonight, and for all our speakers. Let's give them a big round of applause. I learned a lot, and so thank you very much for being our moderator and master of ceremonies. So another big round of applause for Brent and staff. I don't know when we get thrown out of here, and I know that we don't seem to have anything.
If you sign up for all the plans.
Yeah. So But you're welcome to stay and network for a bit. We're not doing an after event or anything like that, which we used to do a lot. We're not doing it anymore. If you have any questions or comments, please see me or any of our co-organizers. Raise your hands, Merrill, Jack, Jeff. If you want to speak at an event, there's an application online. Our next event is the 8th. It's Leading Edge Technology in Healthcare. You can see all these later at Third FTV. And thank you all for coming and have a safe ride home, and hope you enjoy it. Thank you.